Welcome to this session about heart failure pharmacotherapy. We will go through the heart failure medication, their use, their place in therapy, the recommendation of each use. So our objective here, we need to define the sign and symptoms of heart failure, the stages and the classification of heart failure, what medication to avoid, how to diagnose heart failure, the goal of therapy, and the AHA guideline for management of heart failure, the treatment for stage B heart failure, new agents used in heart failure, and pharmacist's role in the treatment of heart failure. Let's start with the definition of heart failure. As if you are working or practicing pharmacy, you will not notice any patient with a diagnosis of heart failure. So heart failure is not a disease in itself, it's just a combination of symptoms or a syndrome due to structural or functional impairment of ventricular filling or ejection of blood. So the patient will have a problem in blood filling to the atrium or pumping through the ventricles. This will result in sufficient perfusion to meet metabolic demands, means that less blood will be supplied to the essential organs like the heart, the brain, and the kidney. And the main symptoms will be that the patient will have fatigue and dyspnea, which is difficulty in breathing. Both of these symptoms will affect the patient exercise. So the patient cannot do any exercise or have limited exercise tolerance. So he will feel fatigue with even walking or mild exercise. Another main symptoms will be fluid retention. So patient will have a lot of fluids. These fluids can be in the lung, causing pulmonary congestion, or may be accumulated in the legs or peripheral organs, causing peripheral edema. So as we mentioned, heart failure is a syndrome. So you will identify a patient of heart failure from his list of medication, which may include some type of medication like listed here, like aspirin, bisoprolol as beta blocker, brentupril as ACE inhibitor, diuretic like furosemide, atorvastatin, digoxin, of course, very famous medication for heart failure, and trinitroglycerin spray, BRN, and a very famous new medication which is sacubitril valsartan. So if you see a patient on a list of this medication, you will identify this one as heart failure patient. So what is the classification of heart failure? Classification will depend on stages and functional classification. The stages is here identified by the AHA guideline and the functional classification by New York Heart Association. So the stages depend on the stage of heart condition. So patient heart may be at risk or they have damage or severe damage. Why the functional explain the exercise ability of the patient. So for AHA stages of heart failure, it's classified as A, B, C, D, whereas in A, patient is at risk, but he don't have any structural or functional heart problems. So this patient, like patient with diabetes, hypertension, multiple sclerosis or atherosclerosis, this type of patient at risk of heart disease, but they do not have heart failure. Stage B, this patient will have structural heart disease, but there is no sign or symptoms of heart failure like fatigue, dyspnea, or fluid retention. This patient, like patient with previous myocardial infarction or left ventricular hypertrophy. Class C, this patient will having structural heart disease, but they have prior or current symptoms. So they have symptoms at the current state or they have from previous. Stage D will have refractory heart failure, require specialist intervention. So they have structural heart disease, they have frequent symptoms that need a specialist intervention. For functional classification, the patient in stage A, they don't have a comparable functional classification in NIHA group, while in B, they are equivalent to group 1, who have no limitation of physical activity and ordinary physical activity don't cause any harm or symptoms of heart failure. For stage C, the very common that they can be classified into the four main symptoms. Class 1, which is having no limitation of physical activity and ordinary physical activity do not cause symptoms. Stage 2, why there is a slight limitation, patient comfortable at rest, but ordinary activity can cause symptoms. Stage 3, there is marked limitation of physical activity, still patient comfortable at rest, but less than ordinary activity can cause symptoms. While stage 4 is very severe, he is unable to carry any physical activity without symptoms of heart failure, or symptom can occur at rest. And class D, of course, will be equivalent to group 4 of heart failure classification in NIHA. Okay, so what is ejection fraction? So ejection fraction is a percentage of how much blood the left ventricle can pump out with each contraction. So it is a measure of percentage of blood ejected during the systole in relation to the total diastolic volume. So how much of the total blood in the ventricle is pumped in a contraction. So it is usually as a percent. So it is the stroke volume divided by left ventricular diastolic volume. So the stroke volume is the amount of blood that is pumped, and the end diastolic volume is the amount that's there in the ventricle itself. And we multiply by 100, we can get a percent. And the patient can be having either normal, borderline, or reduced ejection fraction. In normal, at least it should be above 50 or 50 to 70% of the blood in the ventricle are pumped out, and this patient will have comfortable effect during activity. For borderline, the ejection fraction will range from 41 to 49%, and this type of patient will have some symptoms during activity. And reduced ejection fraction, usually when the ejection fraction below 40%, and patient will have some noticeable symptoms even during rest. So what are the classification of heart failure? Heart failure can be classified into two main types. Heart failure with preserved ejection fraction, when the ejection fraction is still above 50, so patient will still be comfortable. So it's impairment in the ventricular relaxation or filling. So the issue here is the filling pressure of the heart, not the pumping pressure. Before it was called diastolic heart failure because it is related to diastole. And its common cause is hypertension. Up to 90% of cases is due to hypertension. The main cause is left ventricular hypertrophy, and the treatment will depend on optimizing treatment of comorbidity. So this patient will have hypertension, diabetes, or atrial fibrillation. So as long as these disease states are managed well and optimized, so this type of heart failure, preserved ejection fraction, will be controlled. So there is no specific treatment for heart failure, preserved ejection fraction. It's just treatment of the comorbidity or the causing diseases. The second cause, which is heart failure with reduced ejection fraction, this is the most common and the most disease that need more attention and optimization of treatment, where the ejection fraction is below 40% and the contractility in the ventricle is impaired. So here the problem is in the ventricle pumping of blood. And before it was called systolic heart failure. And main causes coronary artery disease like MI or stroke. There is left ventricular dilation, so the left ventricle will be dilated because of the stress on the ventricle to pump blood. The ventricle is exposed to a lot of stress, a lot of time to pump blood, so it will end with dilation in the ventricle. And treatment will be pharmacologic treatment to improve mortality and morbidity of the disease. What are the treatment goals? For stage A, we need to modify the risk factors that cause the disease. And for stage B, we need to treat the structural heart disease. And for C and D, we need to reduce morbidity and mortality. Why we are focusing on morbidity and mortality? This is because heart failure is associated with a high rate of morbidity and mortality. As you see here in the graph, the patient with heart failure who are hospitalized within 30 days, 1 year, and 5 years, their mortality rate is increasing year by year, and it's 10% for the first 30 days, and within 1 year it's 30%, and within 5 years it can reach to 50%. So the patient of heart failure, they are hospitalized, they are at risk of death or mortality, so that the focus of drugs to be used in heart failure is mainly to reduce mortality. And here is some figure about hospitalization, that heart failure account for more than 1 million hospitalization per year, and patient with heart failure at risk of all-cause rehospitalization within 1 month up to 25%. So within 1 month of detecting heart failure, this patient, like 25% with this patient will be readmitted to hospital. So how we diagnose heart failure? So first is to use symptoms, which are fatigue, dyspnea, and edema, exercise intolerance. Then ECG can be done to confirm it. One important test is being used in the ambulatory or clinics can be NT-proBNP, which is N-terminal probenatriuretic peptide. This is a protein produced when the heart is exposed to stress. So during heart failures, the heart is at stress or strain to pump blood. So this protein will be produced in large quantity. So NT-proBNP is used as a biomarker of heart failure. According to the lab result, if NT-proBNP is more than 2000 nanogram per liter, so urgent referral for assessment of echo within 2 weeks. So the echocardiogram can confirm the diagnosis, and this should be done very quickly within 2 weeks. And if NT-proBNP 400 to 2000 nanogram per liter, we need referral but within 6 weeks, but still heart failure is suspected. However, if NT-proBNP is less than 400 nanogram per liter, at this stage the heart failure is not confirmed. So it's a very important test to understand and to interpret its result. What are the drugs that may cause or exacerbate heart failure? So as a pharmacist, you should be aware of a lot of drugs that have a cardiotoxic effect. You can identify this medication from patient list. You can focus more on patients with heart failure or at risk of heart failure or who are on this medication to draw the attention of the prescribers. Medications which are negative inotropic that weaken contractility, so medications that depress cardiac conduction or pumping, and of course from them there is calcium channel blocker, the non-dihydropyridine calcium channel blocker, the old generation like verapamil and diltiazem. Antiarrhythmic like flecainide and dronedarone are very famous to depress cardiac contractility and pumping. Medications that cause salt and water retention, it will cause two harmful effects. It will increase the systemic vascular resistance as they will increase the pressure in the peripheral organs. So the heart will need to do a lot of work to pump blood against this pressure. On the other hand, it increases salt and water retention. It will cause edema and will worsen the heart failure. From this medication, a very famous NSAIDs like ibuprofen, diclofenac, all this medication are to be very careful to be used in patients with heart failure, to be avoided. Some countries, they do not allow use of diclofenac only in severe cases due to the risk of cardiac risk. Corticosteroids are very commonly known to increase salt and water retention due to its glucocorticoid effect. and thiazolidinediones like bioglitazones that is used for controlling diabetes. Also well known to cause salt and water retention, so it should be avoided in heart failure. Some chemotherapeutic agents also are very famous to cause, like anthracyclines, like doxorubicin for treating cancer. Cyclophosphamide in high dose can also cause cardiotoxicity. Fluorouracil and trastuzumab and pertuzumab. So all this list of medication, we should be aware of it, and you should identify in the patient medication list to guide which to discontinue and to be more cautious in using this medication in heart failure. So what is the goal of therapy in heart failure? The first one is to modify the risk factors. So as we mentioned, diabetes and hypertension, and of course obesity will increase the risk of diabetes, should be managed to decrease the risk of heart failure. You need to manage structural heart disease which may develop like MI or stroke. Reduce morbidity and mortality by using medications that have a mortality benefit to decrease mortality in the patients. Minimize sodium and water retention because this will increase edema and increase the patient's symptoms of fatigue and dyspnea. Eliminate or minimize the symptoms like fatigue and dyspnea. Block the neurohormonal activation caused by reduced cardiac output. So reduced cardiac output will increase sympathetic neurohormonal activation and also will increase renin-angiotensin system. So the aim is to reduce these two mechanisms, which will further deteriorate heart failure by using beta blockers and ACE or ARB. This is why these two medications are very important in heart failure. Slow progression or worsening of cardiac function. So what are the medication therapy used for heart failure management? So we'll start step by step, which medication, which place in therapy, what monitoring required during treatment. First group is diuretics, and diuretics are recommended to relieve symptoms due to volume overload. So it's symptomatic relief of excess fluid, and this is very clear from the effect of diuretic to remove excess water from the blood. And they have a place in therapy in patients with evidence of fluid retention. So if a patient having ascites or edema in the leg, so he must be on diuretics at this stage. It have short-term benefit within days that they relieve peripheral edema and congestion because of diuretic effect. It have intermediate benefit within months by improving daily symptoms and increasing exercise tolerance as long as the fluids are removed, so the patient can do exercise more efficiently. They have long-term benefits in month and year, but this one there is no benefit on long term. They don't have any effect on mortality and morbidity. This is why they should be short-term in case of patient having fluid overload. And if the patient is hospitalized, so during hospitalization, there is a goal to reduce patient weight by 0.5 to 1 kg per day using diuretic. So the diuretic dose can be titrated to achieve this target. From diuretics, there is two main groups, loop diuretics and thiazides. Loop are more potent. They increase sodium excretion by 20% to 25%. As long as sodium excreted, so water will be excreted with sodium. This is the principle of using diuretic. They can maintain effect unless the renal function is significantly impaired, like below 15 ml per minute. Thiazide, they have a moderate effect. They increase water excretion by 5 to 10%, still effective, but they lose effect in impaired renal function. So loop diuretic can be used at a lower eGFR than thiazides. What are the monitors that should be done during using diuretics? So very important is potassium. Potassium should be above 4 because they cause hypokalemia and hyponatremia. and hypomagnesemia. And also as well, magnesium should be above 2 milliequivalent per liter to avoid hypomagnesemia. Also, we need to monitor serum creatinine and renal function to avoid AKI or acute kidney injury from overdiuresis. What are the commonly used diuretics? So we have in loop diuretics, as we mentioned, a potent diuretic which can excrete up to 25% of sodium. We have furosemide, bumetanide, and torsemide. Furosemide half-life is 6 to 8 hours. This is why it should be used twice a day, and the maximum dose is up to 600 milligram. So if you are in a hospital setting and you see a dose of furosemide 600 milligrams, so this is normal. The usual dose in pharmacies, outpatient pharmacies, like 40, and the patient can be 40 milligram twice. For thiazide diuretics, there is hydrochlorothiazide, metolazone, chlorsalidone, and chlorothiazide. Hydrochlorothiazide like Ezidrex and chlorsalidone is high gluten. These are very commonly used, and the chlorsalidone have a benefit of long half-life, 24 to 72 hours. So it can be used only once daily. This is a very high benefit and a very effective diuretic. So from thiazide, very commonly hydrochlorothiazide and chlorsalidone. ACE inhibitors or angiotensin converting enzyme inhibitors. So they are beneficial in patients with prior or current symptoms of chronic HFrEF to reduce morbidity and mortality. As we mentioned, we need to block the renin-angiotensin system in order to improve heart failure, because this system is activated and antagonize the effect of heart failure. So angiotensin converting enzyme is converting angiotensin 1 to angiotensin 2, which in turn cause vasoconstriction and increase vascular resistance, and also increase aldosterone secretion will cause sodium and water retention. These two effects will end up with increasing blood pressure. So blocking the ACE enzyme will decrease angiotensin and block this cycle and provide benefit in heart failure. So it's recommended to reduce morbidity and mortality. So this morbidity and mortality benefit is proven from clinical trials. So there is trials on these medications that provide mortality benefit. Contraindication is there is angioedema or pregnancy. It is teratogenic, is totally avoided in pregnant. Precaution, it should be caution in patient with low blood pressure, where systolic blood pressure is less than 80, because they reduce blood pressure. With marked elevated serum creatinine above 3, because they can be renal toxic. Bilateral renal artery stenosis, also in these patients they will produce AKI, and hyperkalemia above 5, because ACE inhibitors are very famous to cause hyperkalemia. So patient with serum potassium more than 5 is at risk of hyperkalemia. The dose need to be titrated every 2 weeks until target dose. So usually we start with low dose, then titrate slowly every 2 weeks to target dose, and usually the benefit from high doses. A very common side effect of ACE inhibitor is that they can cause cough, and this is why it should be discontinued at this stage. This is because ACE inhibitor inhibit kinase, which break down bradykinin. So bradykinin increased, that cause cough. So what is the monitoring of ACE inhibitor? As discussed before, the impact on renal failure. So serum creatinine and potassium need to be monitored 1 to 2 weeks after initiating or increasing the dose. So even if the dose increase, we need to again recheck serum creatinine and potassium. Also, it is normal that the serum creatinine can rise up to 30% at start of treatment. This is normal and the medication should not stop at this stage. The adverse effect is angioedema and is a little bit rare, up to 1%, while dry cough is very common and can be up to 20%. What are the common ACE inhibitors with evidence in heart failure? So we have captopril, enalapril, lisinopril, perindopril, but the most common is lisinopril with a starting dose of 2.5 to 5 milligram and target dose of 20 milligram daily, while the maximum dose is 40 milligram daily. So you need to be aware that we start in a low dose and we titrate the dose upward. ARBs or IRBs or angiotensin receptor blockers. So they reduce morbidity and mortality in patients with prior or current symptoms of chronic HFrEF who are intolerant to ACE because of cough or angioedema. The effect of ARB here that they block the angiotensin receptor in the peripheral organs. So the angiotensin 2 will not reduce its effect by increasing aldosterone or vasoconstriction. So aldosterone receptors are blocked, while ACE they block the production of angiotensin. So they are especially beneficial in patients who are ACE intolerant, so patients who cannot tolerate ACE if they develop dry cough or angioedema. They do not inhibit kinase, so they little effect of cough and angioedema than ACE inhibitors. It should be given in caution also, the same cautions, with low blood pressure, with renal insufficiency, while serum creatinine above 3, and with elevated serum potassium above 5. So what are the recommended and starting doses of ARB? The most common 3 ARBs used in heart failure are candesartan, losartan, and valsartan. Candesartan, Atacand, starting dose 4 to 8 and target 32 milligram. Losartan starting 25 to 50 with target 150 milligram daily. Valsartan starting 20 to 40 twice and maximum of 160 twice daily. Beta blockers, as also discussed from the mortality benefit medication, which is beta blocker, which block the sympathetic activation. So there is one of 3 beta blocker with proven mortality benefit is recommended for patients with symptoms of HFrEF unless contraindicated to reduce morbidity and mortality. So what are the contraindication for beta blocker? You should be familiar with this contraindication. So second or third degree AV block, because they decrease cardiac conduction, so they can cause more block of conduction. When heart rate is less than 50 beats per minute, and with asthma, because most beta blocker can block beta 2 receptors in the bronchi and cause bronchoconstriction. Dosing and administration, we mentioned there is 3 main beta blockers, so not all beta blockers can be recommended in heart failure. There is 3 beta blocker with proven benefit from clinical trials, which are bisoprolol, carvedilol, and metoprolol succinate. So it is added to existing ACE inhibitor when heart failure are stable and patient is euvolumic. So it should be added when the patient is stable, and euvolumic means that he don't have fluid overload. We start low and double the dose every 2 weeks to achieve the target within 8 to 12 weeks. And also avoid abrupt discontinuation because it's very famous to cause rebound hypertension. So it's very important to counsel the patient about using beta blocker who is having heart failure, that they will not notice improvement in symptoms very quickly the benefit can be occur after several months. So what is the monitoring using during heart failure? So as long as it decreased the blood pressure and heart rate, so we need to monitor the blood pressure and heart rate for symptoms of hypotension and bradycardia. So this should be done within 1 to 2 weeks. And if this happens, the dose should be reduced to 50%. And the mortality benefit can be gained from high dose beta blocker. So if a patient who is having heart failure develop hypotension who is using ACE inhibitor plus beta blocker, the strategy is to reduce the dose of ACE because of the benefit from mortality with higher dose of beta blocker. Increased edema or fluid retention, and this is a side effect of beta blocker. This should be monitored also within 1 to 2 weeks of starting treatment. Fatigue or weakness, and this is a common side effect of beta blocker because they decrease blood supply to the muscle. What are these three agents that is approved for heart failure? Bisoprolol, carvedilol, and metoprolol succinate with starting and target doses as mentioned here. Carvedilol to be the most commonly used with a starting dose of 3.125 twice daily and the maximum is 25 twice daily. Bisoprolol once daily 1.25 with a target dose of 10 mg daily. Aldosterone receptor antagonist or ARAs like eplerenone and spironolactone. This is very important medication to block the neurohormonal activation of RAS system because they block aldosterone. So they are recommended with NIHA class 2 to 4 heart failure who have left ventricular ejection fraction 35% or less, unless contraindicated, also with proven morbidity and mortality. So their benefit is that they decrease mortality by 30% and decrease hospitalization by 35%. So what is the dosage and adjustment? So they have different dosage and adjustment according to eGFR if it is above 50 or 30 to 49 ml per minute. So the initial and maintenance doses can be reduced to half in case of reduced renal function. And if potassium rise above 5 because they are commonly to cause hyperkalemia, so treatment should be withheld for a maximum of 72 hours until resolution of hyperkalemia and renal insufficiency. What are the monitoring needed for aldosterone receptor antagonist? Very important to monitor potassium because they cause hyperkalemia and serum creatinine due to their effect on the renal function. So this should be done within 2 to 3 days of start and 7 days after starting therapy. Later on it should be monthly for 3 months for the first 3 months, then every 3 months thereafter. And if the dose of ACE or ARB increased, we need to restart the monitoring again. The dose can be reduced to 50% of potassium is very high, above 5.5 milligram, because it's a medical emergency that may cause arrhythmia and need patient admission. Gynecomastia is a very common side effect to be occurring with aldosterone antagonist, but it is more common with spironolactone up to 10%, and at this stage the best option is to shift patient to eplerenone, which is having no gynecomastia side effect. So there is a warning about using aldosterone antagonist in hyperkalemia or renal insufficiency, that the inappropriate use of aldosterone antagonist is potentially harmful and cause life-threatening hyperkalemia and renal insufficiency in these cases. So this is harmful to use spironolactone or eplerenone in these cases where serum creatinine is above 2.5 mg per deciliter in men or above 2 mg per deciliter in women, or when EGFR less than 30 ml per minute, or serum potassium more than 5 milliequivalent per liter. Hydralazine isosorbide dinitrate. This medication will have a beneficial effect in African American to reduce morbidity and mortality who are using optimal therapy with ACE and beta blocker. So what are the selected patients? They are African American with HFrEF who still symptomatic despite using ACE and beta blocker and aldosterone receptor antagonist. Initiation and maintenance. The initial dose should be a combined of two medication, 37.5 mg hydralazine with 20 mg isosorbide, one tablet 3 times a day, can be increased to 2 tablets 3 times a day, with a maximum of 2 to 5 mg hydralazine with 120 mg isosorbide dinitrate. Risk of benefit, poor adherence. As you see, the patient can take up to tablets 3 times, like 6 tablets a day. So there is an issue with adherence here. And a common side effect due to that nitrate will cause vasodilation, it will cause dizziness, headache, and GI complaint can occur. Also, slow titration is needed to enhance tolerance so that the patient will be accounted to the side effect and he can tolerate the side effects slowly. So till now, what is the heart failure treatment guidelines? So if we have a patient with HFrEF or heart failure reduced ejection fraction, stage C, as we mentioned in the functional state, who have current or prior symptoms of heart failure with structural heart disease, NEHA class 1 to 4. So the first line or class 1 level of evidence A is to use ACE or ARB and beta blocker. So initially ACE and ARB is recommended if patient having intolerant effect from ACE like cough or angioedema. Then and beta blocker can be added when the patient is stable. Then for all patients with volume overload who are NEHA class 2 to 4, so at this stage we need to add loop diuretics like furosemide. For persistently symptomatic African American, so patient is still using ACE or ARB plus beta blocker. He is African American, but he's still asymptomatic. So the best option is to add hydralazine nitrate. For patients who are NEHA class 2 to 4, provided with estimated creatinine clearance more than 30 ml per minute and potassium less than 5, so they have good renal function and no hyperkalemia, this class of patient will be eligible to start aldosterone antagonist like spironolactone or eplerenone. And we will continue in the second part.